It was excellent to hear from Dr. Stewart and Stacy Richter. Thank you for that enlightening conversation. Hi, I'm happy to introduce this next session. Before I introduce our speaker, a couple logistics items. Dr. Waldron, who will be our speaker, he's going to present for the first 15 minutes of this session, leaving 10 minutes for Q&A with him and Bethany Burke. Please leave your questions in the Q&A tab. You'll see that on the right-hand side of your screen. So with that, I'm pleased to introduce Dr. Stephen Waldron. He is the Vice President and Chief Medical Informatics Officer at AAFP. He is a nationally recognized expert in health information technology and has over 15 years of experience. Prior to joining the AAFP, Dr. Waldron was a National Library of Medicine Medical Informatics postdoctoral fellow at the University of Missouri. Dr. Waldron is also a trained family physician. So with that, Dr. Waldron, welcome.
Thanks, Mark. It's great to be here and talk a little bit about our work at the AAFP and our Innovation Lab and our collaboration with Hint around looking at prospective payment and direct primary care as an example of that. So what I thought I could do today is talk with you a little bit about the labs and why the Academy decided to start these labs. In family medicine, I'm sure this is true of primary care in general, and unfortunately also true for some subspecialty care as well, that there are some existential threats. And in family medicine, those three that we see are the clerical burden that's really burning out family physicians almost at epic levels. And the next is this transition to value-based payment. Without really being able to understand that downside risk, it has the potential to burn down practices. And we know we need to move away from fee for service, and value-based payment is one of those options. And of course, direct primary care is also another value-based model relative to that. So I'm glad to talk a little bit about that in a little bit more detail. And the last problem that we see is this fourth industrial revolution of artificial intelligence and machine learning. And it's going to fundamentally change what it means to be a physician and to be a family physician. I just don't know if that's 10 years from now or 25 years from now. But our hypothesis at the AAFP is that if we can drive innovation focused on the needs of family medicine, that we can address these particular issues. And of course, we can't have any presentation without recognizing the impact of the COVID-19 pandemic. So in addition to these three problems, we've also been looking at how to support practices as they're managing the surges that we saw early in the pandemic, and also really understanding the practice viability. Again, going back to this notion of the fee-for-service model and having to have in-person visits, and without that, due to the pandemic, the real problem relative to that. So in the Innovation Lab at the AAFP, we believe that family physicians must primarily care for patients, not care for their IT systems or for their payment models. And that for us in the technology space, IT needs to work for us, not against us. At the AAFP, we've been advocating for change and improved interoperability for a long time. And we're just no longer going to accept the status quo. So in addition to that advocacy effort, the Academy put forth a special project to really drive that innovation into family medicine. And one of those projects is this AAFP Innovation Lab. So the labs themselves are situated into three different levels. Our first labs that we do with a particular innovation is really focused on a proof of concept. So we understand that these solutions are working outside of family medicine, or that they're working in pockets in family medicine. And we really want to make sure that we understand that not only is it effective, but it is adoptable for family medicine. So we look for two or three practices to adopt the solution, and we do an evaluation pre and post. During the pandemic, we've added in this component to be able to do a retrospective. So we don't look for actual adoption, but we go out and talk to physicians that have already adopted the solution. Our next phase 2 was really looking at proof of adoption. So making sure that we understand how this adopts across the diversity that is family medicine. And here we're looking for 100 physicians across the membership. You'll see here I talk about clinicians because we also have mid-levels and other clinicians that participate in the family medicine practices, and we want solutions that work for them as well. After each of those phases, we create a report that talks about the findings, what we found relative to that. If those two are successful, that they really do address one of those burning problems that I spoke with you about, and it shows a really demonstrable improvement into family medicine, then we would consider that an essential innovation for family medicine. And at that point, we really want to talk about how to educate members around that in regards to who it's essential for and what are things that lead to greater success using that type of innovation. So this is our roadmap at the Innovation Labs currently. So at the top, you see some of the key challenges in family medicine. So you have those three burning problems of the clerical burden, the value-based payment transition, and that integration of AI and ML. And more specifically, underneath that, you see the problems specifically that we're really focusing in on. And in the bottom in the blue, you see the essential innovations that we're looking at. And while we started looking at technology innovations, we rapidly understood that we need to look more broadly at other types of innovations, such as the direct primary care that I'm going to talk with you about in a little second. But our first lab that we worked with is on around documentation. So we know there's a significant burden in documentation where physicians are spending, twice as much time doing administrative desk work than they are seeing patients. So when we looked into the marketplace, we found this notion of a product called an AI assistant for documentation. So think of this as a Alexa or a Siri type of device that you can tell this is what you want to document for your note. And we partner with a company called Suki that has an AI assistant for documentation. And we were able to determine our first two phases of our labs with them that we saw over a 60% reduction in documentation time and over a 70% reduction in documentation after hours. And we saw greater improvement in practice, better improvement in workflow, better improvement with their EMR. The next lab that we look at is also an AI assistant looking at chart review. So being able to do chart prep really well for patients that are more complicated. So instead of hunting and pecking across the EMR, trying to find all the data across multiple different pieces, all that data is pulled together in kind of a problem-oriented summary of all the data that you need. So for your diabetic, here's all the labs that you want about. Here's the result that was from the referral to ophthalmology to do the diabetic retinopathy screening. It's all right there in one place. So we're just excited about that, showing that, again, about a 70% reduction in pre-visit planning time to review all that data. But the next lab I want to talk with you about is the focus around the direct primary care. And that's the other one that we did with Hint, and we're looking to do one again with Elation on the clinical side. And you can see there's a couple other labs that we're working on moving forward. So I'm sure for this particular group, I don't have to talk about this particular problem as much as I would in some other areas, but the fee-for-service hamster wheel is a real problem for family medicine. It's leading to short visits. Our physicians tell us in our lab working with Hint that prior to implementing DPC, they didn't feel like they had ample time to really take care of the issues of their patients. And also they were holding large panels of patients that made it more difficult to be able to do that. And just did not have enough time in the day to take care of patients and do all the administrative work that was needed. So they end up having to do a lot of after hours work, what a lot of physicians call pajama time. And they found out that they really had to justify everything that they did. And they had to fight tooth and nail to get paid for what they did. And when we talk with folks in the DPC space, since they were looking at using this prospective payment model, they didn't have to deal with that insurance model of having to figure out how to get paid. They also understood that they didn't have to have office visits to get paid. So they were able to see patients in the office when they needed to see patients in the office, which gave them more time to be seen in the office. So they had ample time to be able to be seen. And that upfront recurring payment from that prospective payment made it such that they didn't have to spend a lot of time and overhead to be able to get paid. And that value was really tied to the patient. So the patient was able to determine that value and they would decide to quit payment and move to another practice if the value wasn't there. And we just found that there was a lot of the physicians saw that a lot more professional satisfaction. Again, going back to that first statement I made when I said what we believe is that family physicians must primarily care for patients, that's what they were able to get back to. But one of the big challenges in DPC, of course, is making this transition to now, how do you manage that prospective payment? And to do that, you need to figure out how do you do the enrollment, how do you do your own plan administration, since now you have the plan, and how do you manage the eligibility, your billing, your invoicing, payments, collections, credit card processing, all of that. And what we found is a lot of those docs were using a Hint-based solution or another solution in the marketplace to manage that. So we wanted really to understand how does that really work and what were the features that made that work extremely well in practices. So we embarked in a phase 1 lab with Hint to really look at those practices and really understand not only the DPC component, but also the Hint component to those practices. So a little sneak peek of the results that we have in our phase 1 lab. So I mentioned to you that we look to have 10 clinicians participate in these labs. So we have data on another one. So we have 9, and we're working to finish our data collection on our 10th one. So you're getting to see some early results here that we'll be publishing toward the end of the year. But this, again, was a retrospective looking at physicians that have already adopted the DPC and the Hint model. And we did a set of clinical interviews with them, talking with them about how their practice was prior to implementing those 2 solutions and after they've implemented those 2 solutions in their practice. And what we found was that they were able to have, on average, about a 30-minute increase in visit times for their patients. And that when they talked about the frustrations of getting paid, they told us, and this was a direct quote, get paid easily, that there was a really great increase in satisfaction. A couple of our docs said, well, in the fee-for-service world, they really looked at their AR and managed all these claim denials that came in. But in this new model of the DPC, being able to manage a prospective payment, just every once in a while, they went in just to make sure that the money was actually going into the bank. They said every time that it was, and it just made the satisfaction much, much greater for those docs that did that. The other thing that we learned that we didn't seek out to understand when we started the lab was really the help that Hint has been providing some of those practices to really make that transition to DPC. So the Academy has been doing a lot of efforts in helping educate physicians on how to adopt and make the transition to DPC. But we really understood the real value of being able to do that and walk those physicians forward in some of those training things that Hint was putting in with their solution, their software solution. So we're really excited about the lab that we did, and we're working right now with Hint to try to start up a phase 2 lab where we're going to look to recruit 100 family physicians to really participate in the lab so we can really understand that adoption of that prospective model of payment and how that works really well and how you need to have what type of feature set to really support that moving forward. So we're really excited about that. So I really look to you if you're interested in DPC or have been thinking about it, or you've been thinking about Hint as a particular solution, we'd love for you to join us in the lab so we can really study that and really understand that moving forward. So if you are interested in that, you can actually go to a link here that Hint has set up, gethint.com/AAFP Innovation Lab, and put in your information, and you can get set up to be able to be in the process when we start to kick off that lab very soon. If you're interested in any of the other labs that we have, you can send me an email at ehealth@aafp.org. And again, our other labs that we have are focused around EMR documentation, focused around that pre-visit planning and pulling together the summary, and that DPC one around elation is really going to focus on the clinical side of that. So how can that DPC model support more innovation to really take better care of patients moving forward? Because we found that time savings with DPC awarded those practices that opportunity to do that. And the fact that they weren't tied to encounters also gave them new opportunities to do that. So we're really excited about that as well. So I look forward to any questions that you have of us at the AAFP. So I'll turn it back over to Mark.
Great. Thank you, Stephen. I appreciate that. Good stuff, and we enjoy working with you and look forward to continuing working with you in phase 2. Bethany and Stephen, there are a few questions that I will share with you from the audience and beyond, and love to get your thoughts on them. In a follow-up to the lab, Stephen, maybe to go a little bit on the phase 2 piece, for practices that want to participate in that, what in generally will it require from them? What should they think about? Is this a large effort on their part, et cetera?
Sure, that's a great question, Mark. So part of our labs, I talked about at the beginning, the two questions that we want to be able to answer is, are these solutions effective and are they adoptable? So in that notion of adoptable, it means two things. So one, we want to be able to try to get the labs as close as we can to what's it going to look like kind of if you were going to adopt this technology. So we try to make the lift on the practices very minimal compared to what they would do just to have to deploy the type of solution in their practice. So it does require you to participate in an interview with the AAFP. So I and another physician are doing those interviews. So we'll ask you a series of questions kind of up front about your current situation in your practice, ask you a little couple questions about why you're making that transition to DPC, what you're trying to get out of making that transition, and kind of why were you thinking about Hint as a tool as you're making that transition, or if you're adding that to your practice if you're already a DPC. So there at max, you're talking about 2 1-hour interviews with us, separated by 30 days of using the product. And then the other thing is that we try to get it set up too, that it's looking like a commercial relationship. So you will need to sign up with Hint like you are going to be a customer of that. But we've worked with Hint to make sure that the pricing there and the ability for you to give that trial there really works. And at the end of the lab, if it just doesn't work, you have that ability to discontinue your participation. So it does kind of decrease the risk a little bit than being able to go out and purchase it. But and I think, Mark, too, that you guys don't have long contracts like we see in a lot of other healthcare solutions that we try to implement into healthcare. So not as much of a value, unfortunately, for our members that are participating in the lab as it would for some other solutions that are out in the marketplace.
Correct, and we'll drop into the chat a link to where they can express their interest if they want to move forward as part of that phase 2. There's a question for Bethany and Stephen. AFP supports a physician's choice to provide healthcare in any ethical healthcare delivery system model, including DPC. Can you describe whether you've seen increased interest in DPC from your members? And if so, what are their main questions about it?
Yeah, I can go first. So this is a big part of my portfolio at my job, is managing kind of our direct primary care work. It's been really exciting to see this model get adopted across our membership. I mean, right now in our latest survey, we had about 5% of our 133,000 members in a DPC practice, with another 1% like actively transitioning to this model. That's nearly double from a couple of years ago in 2017, when it was just like 2.7%. And if you think about it, that's just really incredible growth. So, I mean, even though it remains a small portion of our membership, I've just been excited to see year over year different physicians and groups adopting this model. I would say one of the things I'm actually most proud of is just the awareness of the model amongst our membership. When we first started supporting DPC in 2014, 2015, they had no clue what it is. And our survey just showed that nearly like 85% of our members know what DPC is. So now I really take my job seriously, that I need to show them what DPC can do and the impacts of the community so that they're inspired to possibly adopt this model. I would say for me, some of the questions that I get are just like, is it sustainable in their community? So again, that's where I'm just like, I will show them how it's being adopted across the nation. And that's a big goal for me over the next few years.
Yeah, I would add to that. One of the things that I saw when talking with physicians and part of the labs was two things. One, groups that were looking at doing hybrid. So there were actually larger organizations that were really driving DPC model, working on the small employer side, allowing practices that weren't ready to make the full commitment to kind of get their toe wet. And when I first started talking with DPC back with Bethany several years ago, that was the biggest challenge, is that if you try to do hybrid, you couldn't get enough value in regards to the decrease in the administrative overhead and all those things to make it really work. But some of the advances that have happened in some of the technology and stuff, you can start to do that. So I'm really excited about that being able to drive a little bit more adoption. And the other is now we're seeing a lot more entrepreneurs in that DPC saying, well, I started my practice, I added another partner to my practice. I'm talking with another practice, let's combine. And now they're starting, a multi-site large practice all focused around DPC. So I think we'll continue to see accelerated growth. But again, I always hate to pull out the crystal ball because I'm almost always wrong, but I still think that's pretty certain that we'll see a significant growth in DPC over the next couple of years.
Yeah, I think what both of you are saying is pretty exciting stuff. And maybe part of your last point, as more providers are getting into DPC, there's more role models for those who want to do it and figure out how to do it. So that's great. Yep. For Bethany, based on Dr. Stewart's comments, does AAFP believe that policymakers and stakeholders are truly starting to understand the negative impacts of having de-emphasized primary care?
Yeah, I think like Dr. Stewart mentioned, we still have a lot of work to do, but I really feel that COVID made them look really hard at what the undervaluation and investment in primary care has done for our communities. I mean, I think throughout the pandemic, the AAFP has really pushed policymakers to realize that if they had invested in primary care, some of this stuff maybe would have gone a little bit better. So I do think they are starting to realize the importance and investment of primary care, but we still have a lot of work to do.
Got it.
Mark, I guess maybe just one of the concerns that I have as we've started to look at this. So I also do a lot of the stuff in the telehealth related space, and we're seeing a lot of, virtual only kind of models being able to be deployed. So we're seeing a lot of new models for primary care, or what people are saying is primary care. So I think we also have to be very cognizant when we talk about primary care that we're very clear about what we mean about primary care, and that we know from the evidence out there, that the 4 C's, of course, for primary care being coordinated, being comprehensive, having continuous kind of continuity of care, and make sure you have that connectivity for the patient so they have that access. That if you don't have those, then you're not going to get the value of primary care. So we also have to make sure not only are we getting that investment in primary care, but they're actually investing in true primary care, not something that's called primary care as well, which I think is going to be a concern for us moving forward. And us being our primary care industry, not necessarily us being the AAFP, which it is. But
yeah, important point. Last question we have here, and this for either of you, how best can the individual practices and clinicians in attendance here support AAFP's efforts to change the role and financing of primary care? Is there stuff that they can do on the ground, grassroots, or how do they best work with you guys?
I can go first, then I know Stephen has probably thoughts as well. To me, I think it's really about showing policymakers and legislators all the great work that primary care physicians are doing on the ground in their communities. Like, we really need to get physicians connected with their state and federal representatives so they can tell their story and showcase all the work that DPC and primary care is doing across the nation. So that would just be, I guess, one of my biggest things is let's get connected, because federal legislators will listen to their constituents and people in their community, and they're the ones that are making these decisions. So,
yeah, I mean, I completely agree with that, Bethany. And so a little bit of naiveness here on my part relative to name. So if I misspeak, call me out, either Bethany or Mark or somebody in the chat. But I think what a lot of folks think about DPC in the policy space is they've heard these things around concierge medicine, which was the old kind of model of, a high cost, and you added on top of some type of, fee for service type of model in the practice, and thinking that, oh, well, this is for people that have money. This is for the folks that are well off, and that's the model. And I think being able to just blow that out of the water as a myth is going to be really important. I've just been kind of blown away with these interviews that we've been doing with Hint in the first phase of our work, because we asked them about how many uninsured and underinsured people that they take care of in their practice versus what it was before. And it was always more, no matter what was going on. And it was, 30%, 40%, and sometimes 50 and 60%. And it's just because these models are affordable for these patients that don't have any other means, especially the folks that are in, employed enough that the business isn't big enough to have a really robust healthcare plan, but they could pay for a $50, $75 a month plan for their members to get good primary care. So I think that's one of the things that I think we have to tell these policymakers and show them that it's not for the well-to-do, it's for everybody. And I think that's really important.
That's a great point. I mean, DPC has fantastic value, I think, as all of our attendees here would attest, but making it clear that that is actually broad-based and it actually can increase access for people right now who might not have insurance or access. We're going to actually be releasing a blog around DPC misconceptions, and I think what you just spoke about is something that'll be part of what we'll speak to there. We've got about 1 minute left, so I'm just going to ask one last question for either of you. How has the AAFP gotten involved in educating medical students and residents interested in family medicine, alternative models, specifically about DPC? The next generation, how do we make sure that they're aware? And is AAFP focused on that?
Yeah.
So this is, go ahead, Stephen. No,
I was going to say one thing that we're going to try to add to our portfolio is we have a national conference for residents and students every year, and really be able to put the stuff that we're doing in the Innovation Lab forward to really showcase some of the great things that are happening and the innovations that are really happening in family medicine. And sorry, now I'm blanking because I was trying to read the chat and I saw the minutes and then I lost it. So go ahead, Bethany, finish up on me. Bail me out.
No, that's great. So like Stephen mentioned, definitely highlighting direct primary care at our national event for students and residents every year has been really important to us. We also host a big annual event that one of the key things is getting medical students and residents there for free or cheaply. We are also working with program directors to help them understand this model so that they have curriculum and resources to use as they're educating these cohorts. So I just think it's very, very important that we continue to educate them and get them interested in the model, even at the medical student level. So,
yeah, and I would say one thing that you could do if you are a DPC practice now is reach out to your local, residencies and medical schools and offer to be a preceptor and show them what DPC really looks like in practice.
Fantastic. Well, thank you both for your observations, your contributions, and to Dr. Stewart. Hint looks forward to working with AAFP moving forward. And with that, we'll close this session and appreciate everybody and another exciting session coming up.
Thank you.
Thanks, Mark.